There was even a contest, like what was the worst Nurses Week gift you got from your hospital?
What was the winner?
A bag of rocks, because you're a rock star.
Oh my goodness.
I know, could you even imagine?
Oh.
So right now, about 1 in 5 bedside nurses say they're going to leave the bedside in the next 5 years. So we're losing 20% of the nurses that are in the hospital taking care of patients within the next 5 years. We do not have the ability to replace that number at this point.
Hello, welcome to the Litson Podcast Studios. My name is Matt Gibbs. Today I'm honored to be joined by Dr. Jennifer Hitt.
Thank you.
Dr. Hitt is the president of the Tennessee Nursing Association. She's also the executive director of the Tennessee Center for Nursing Advancement.
That's it. It's a mouthful. It's a lot on a business card. So the center, like you said, is funded partially by the state and partially from a gift from Ballot Healthcare. And we have 4 different things that we focus on. We focus on data collection. So we want to know where nurses are and where nurses aren't in the state so that we can fill those holes.
Big time problem in Tennessee. I'm from rural West Tennessee. I've seen firsthand what closures do. Mm-hmm. Shortages are part and parcel to those closures. How do we stop the bleeding? How do we get ahead of it?
That's a great question, because we've tried a few things and it hasn't seemed to make a dent in the problem. We have not just a nursing shortage, we have a problem with nurses at the bedside. So right now, about 1 in 5 bedside nurses say they're going to leave the bedside in the next 5 years. So we're losing 20% of the nurses that are in the hospital taking care of patients within the next 5 years. We do not have the ability to replace that number at this point. They're reporting burnout. They're reporting, unsafe staffing ratios. They're leaving for, desk jobs that pay more, and it's just better to their lifestyle. And so we really have to address that role more than just say, okay, we're going to train more nurses and see if that sticks. That's what we've been trying to do. Our approach has been like, well, let's just train more nurses. We'll just encourage more nurses to come into the state, but they're still leaving at greater rates. And so we really have to look at how we're dealing with bedside nurses. And that's one thing that the center is really looking at, is what can we do to keep people at the bedside. Especially since COVID, we've seen a huge rise in violence against healthcare workers. Even the Hitt had a storyline about violence against a nurse. And so that's really driving people away from the profession. They say, I'm not here to risk my life for this. Yeah. And so I'm just going to walk away from bedside nursing. And, to some extent, I can't blame them. We did have some legislation in 2024 that helped a little bit. Yeah. I don't think it went far enough, though.
Yeah. What is driving the violence? What?
I think everyone's frustrated, especially since COVID. There's a lot of frustration when you're sitting in an ER for hours upon hours waiting. That's driving up frustration levels. I think drug use, too, drives up a lot of the frustration levels, and we've seen that with increased opioid uses and things like that. But society's just different now. I don't know how to explain it. Since COVID, society has changed a lot, and I think expectations have changed. I worked in the emergency department. It's very, things are changed. And so people walk in more frustrated, and there's a lot of mental health that's been unchecked. The general public doesn't have an understanding of, how dangerous it is, not just to physically attack somebody, but just the implications from that and the ripple effects from that. Yeah. We've also had to deal with hospitals who have been discouraging nurses from reporting incidences of violence. They don't want to deal with that. There's some great hospital systems out there that are really attacking it head on, and I appreciate that, but there's some that are just kind of want to sweep it under the rug, and until we know exactly how frequent this is happening, we really can't do what we need to do to solve it.
Can we throw money at the problem?
I don't know about throwing money at the problem. I think the example I always give is, people know that when you get on a plane now, if you even raise your voice at a flight attendant, you're thrown off the plane. Since 9/11, there was a zero tolerance policy for that. The same is not given for nurses. It's almost like they're expected to take the punch sometimes, and that's not fair. I had a student that was assaulted, and I called her that night to check on her, and she said, "Dr. Hitt, I know this comes with the territory." And I said, "Please don't say that, because it certainly does not come with the territory to be assaulted as a nurse." And I think until we get that zero tolerance mindset, I don't think it's going to change. I think people need to know that it's a felony in some cases. It needs to be a felony in all cases. Yeah. And they're not there yet. So that's why I don't think the Tennessee legislation went far enough.
Got it.
Yeah.
What are some suggestions for health facilities to make an environment more healthy for a nurse to help the retention problem?
I think they need to look at workload, like we talked about.
Yeah.
They need to look at fair pay for nurses,
Yeah.
and they need to look at what we call meaningful recognition too for nurses. I mean, I think that there's a lot of nurses that don't get recognized for what they do, and hospitals need to do a better job of taking care of the nurses that are willing to stay and work at the bedside.
Gotcha.
And they're just not. You know, the day of the pizza party as a thank you is gone.
Yeah.
Especially this younger generation, they don't care.
Yeah.
You know, there's these awards that they give out. The younger generation does not care.
Yeah.
If you get on TikTok, they make fun of it. So, yeah.
Gotcha.
There was even a contest, like, what was the worst Nurses Week gift you got from your hospital?
What was the winner?
A bag of rocks, because you're a rock star.
Oh my goodness.
I know. Could you even imagine?
Oh my goodness.
Yeah.
No, I can't, and I'm sorry for.
Yeah, those poor
Apologies in
nurses.
advance.
Yeah. Here's a bag of rocks. Like,
Yeah. I mean, I understand there's an element of trying to create morale,
sure.
but I think that a nurse knows that they're walking into a difficult environment
Right.
from the jump.
Right.
Like this is it. So I clerked in a courthouse in Rutherford County, and the judges I clerked for there said the only good thing that happens at a courthouse happens after 1 o'clock on Friday when we do the uncontested adoption docket.
Oh, wow.
So that
Yeah.
after 1 o'clock is when the adoption, there's pictures and there's
Oh,
celebrations
yeah.
and there's cake and balloons. Monday through Friday morning, it is not an environment of
Yeah.
putting your feet up and relaxing. It is a very difficult environment to work in. Ditto.
Hospitals are like that. I mean, I always
Ditto.
say, you know, we're meeting these people at their worst days generally, unless
Yeah.
it's labor and delivery.
There you go.
And hopefully that's not their worst day, but sometimes that situation does happen too. But we're meeting people at their worst day.
Yeah.
And it's very hard to go in and day out knowing that you're meeting somebody at their lowest.
Yeah.
That's something we've been working on with some wellness programs so that nurses are taking care of themselves first. Because we typically have not done that in the past. We've very much put everyone ahead of us and
Yeah.
skipped lunches and skipped breaks. And now I think we're starting to say, no, you have to take care of yourself first. You're just going to burn out.
Do you have a feel for how quickly burnout onsets from?
You know, I actually was having a conversation with somebody the other day about this with new graduates because we've seen kind of a spike in new graduates leaving the bedside. And I said, you know, I think we've done this to ourselves a little bit because we've for years said nursing is a calling. It's a calling. And then when you get out and things don't look just how you thought they were going to, you become kind of disillusioned with the profession. And I said, I think we need to do a better job as nurses of painting an accurate picture of what those first year or two are going to look like for new graduates.
If we think of the workforce as a pipe, there's a lot going out.
Yeah.
Are there equal numbers coming into the pipe?
Now there are. We had a dip after COVID. People saw what nurses were doing and they didn't want to go into the profession. We're just now getting back to pre-COVID numbers. We still are not training enough. One thing to look at is foreign nurses coming in. We've had a lot of foreign nurses leave. We've had a decrease in the number that have had visas approved, so there's been visa issues getting foreign nurses in. Actually just went to India in February, met with some schools there, trying to match up curriculums so that they did want to come in, that they had an Americanized curriculum. But we're not there yet. We're still not training enough, but bigger problem is we're not keeping them too.
Didn't work for EMS, for the Board of Emergency Medical Services, right at the tail end of my tenure at the department, and that was EMS is facing similar problems.
Right.
There's just,
Oh, yeah.
you know,
Paramedics. Well, we're trying to take the paramedics. So I think we're doing, sorry, paramedics. We're taking the paramedics and making them RNs.
Yeah.
So, yeah.
But that is a bridge,
That
right?
is a bridge. We've
you're
been
trained.
in discussions with some other states, Missouri and Mississippi, who, if you're a Naval Corpsman, Army medic, you can come into their state and take the LPN exam.
Yes.
And then bridge into an RN. I said, we need to get on that. Our neighbors are already doing that. So
Yeah.
that's something we're actually going to look at next year's legislators, maybe trying to get some legislation proposed for that.
Yeah.
Just a great way to get veterans and
Sure.
more people into the
Sure.
pipeline.
If it's a binary choice from you between people coming in the pipe, you need that end of the pipe bigger, or do you need the end of the pipe where people are leaving? Do you need that to be smaller?
I think the end of the pipe. We definitely need to work on, it's easy to bring people in.
Yeah. The center received a shout out.
We did.
In this
Yeah.
legislative session. It was specifically named in a bill that, quite frankly, was pretty monumental from a standpoint of telling other states, hey, we're going to pause on you for a little
Yes.
bit because we got to figure out our own.
Yes.
Walk me through that.
So this bill came from feedback we were getting from the deans and directors of some of the schools in the state who were having difficult times finding clinical space and preceptors for students, particularly nurse practitioner students. And what we've found is since COVID, we had a huge number of schools applying to use clinical space in the state of Tennessee, which was then causing the Tennessee schools to compete for these space. Clinical space and preceptors are a limited commodity. There's only so many and so much that we have in the state. And so we said, well, where are they going? And then we went to look and we had no data on where these people were going. And we said, okay, first thing we need to do is put a pause on new programs coming in. And we need to get a better handle on what schools are coming in, where they're sending students, what the oversight of these students looks like, because we know that a lot of these schools are online. So are they getting the proper faculty oversight that I know that the Tennessee schools are providing? And so we asked for a 2-year moratorium on new out-of-state programs coming in getting approval, because they do have to have approval from the Board of Nursing to set up clinical space here in the state of Tennessee. So that was approved. We actually only had 1 no vote. So that was I'm not salty about that at all. No, just kidding. It was great. It was a good experience. Senator Rusty Crowe was our sponsor. Representative Terry sponsored it in the House. I think they understood when we started talking about, state schools can't pay for preceptors. A lot of these schools are paying for preceptors. It's causing some serious problems with competition. And we want to make sure the Tennessee schools are taken care of first. We wanted to take a little bit of time because we also said whatever recommendations we have to the board, that we do it collaboratively with the board and the deans and directors, and that they're all evidence-based. And so I said, we just need 2 years to get this to you. Because some of them said, why don't you just give us a bill now that addresses these? And I said, because we don't have the data to support that right now. So we've got our 2 years. We're going to go back next year with some recommendations on how we should deal with new out-of-state programs.
You are eating the elephant one bite at a time.
Correct.
What's your first bite, so to speak? What are you looking at out of the gate?
First thing we have to do is figure out, and this is something that the Center's already started doing, is figuring out the schools that are here now, the out-of-state schools, where they're sending preceptors and what that oversight looks like. So we've been in contact with some of these schools and had surveys sent out. Once we have a better handle on the problem, I think we need to look at limiting some out-of-state programs, making sure that Tennessee schools have priority over out-of-state schools. We need to look at the issue of payment, like how is that going to be addressed, especially since state schools can't pay.
The hope that studying this problem elucidates how you're going to attack it, or are you attacking it in the hopes of solving the problem in real time?
Well, I think we definitely are a data-driven center, so we want data first to say what the problem is, because that was a question we got asked a lot. Was, well, how many out-of-state students are here? And we said, we have no idea.
No clue.
No clue. We just know they're here.
Yeah.
The oversight issue was another thing. So I think we've got to have the data before we attack that's just a nursing way of doing things.
I want to discuss a concept that's kind of near and dear, especially with RxLaw Group, medical spas, IV hydration clinics, all the rage. I remember, it feels like it was a decade ago, the first time I had heard of the concept in Nashville, Tennessee, bridesmaids capital of the world.
That's right.
Bachelorette capital of the world. Somebody came up with a concept, and it came up in complaint review. Is this legal? And you talk about 6 lawyers, 3 nurses trying to sort this 10 years ago.
Yeah.
How do we make a med spa safe?
I think you have to have licensed individuals that are appropriately trained. And appropriately trained is another thing, because this isn't something that we teach in nursing school. So how does a nurse that wants to go into a med spa, how do they actually get training for that? And is there, a certification program or something along those lines that they can do? Because it's not something that's trained in nursing school. So same with physicians. If a physician is going to run one of these spas, or a nurse practitioner, do they have the appropriate training and certification? And it might be something that regulations have to come down the pike that say that they do have to have a certain level of training and certifications to do that. So I'd just be very leery of unlicensed individuals performing these things, which we know happens. The IV clinics, there's a lot of people with underlying health problems that you give them a bag of fluids and that could actually kill them. And so unless you're testing people and doing blood draws and things like that beforehand, it can actually be very dangerous to give a bag of fluids, which to us sounds very innocuous. Okay, you're dehydrated, get a bag of fluids. But if you have an underlying kidney problem, it could push you over the edge.
See aesthetics as a concept here to stay.
It is here to stay. It is. Big business.
Yeah, especially as we roll out miracle weight loss drugs that we've been searching for since the fountain of youth, right? Like we have been trying to find something where I don't have to starve myself or run 4 miles.
Right.
We talked about time. I mean, good luck getting a workout in on a 12-hour shift day.
Right.
And so I think it's here to stay. The regulation, the training, are there other concepts that we can implement inside of MedSpa to make it safe? How do we evaluate supply chain, record keeping?
I mean, that's something that I'm not exactly sure. I mean, you hear stories coming out of places where people are being injected by things that they didn't think they were being injected by. And so I think there probably does need to be, even from a federal standpoint, more oversight into products that are coming in, because we just want to be safe. And people sometimes gravitate towards the cheapest option they can find when they really want a service. And so what exactly does that look like?
Yeah.
But from a supply chain, I could totally see we probably need more regulation on products and where they're coming from.
Yeah.
And transparency with the people that are coming in about their training, about the products and things like that.
Aside from practicing law, I like to just ask questions generally.
Yeah.
And I would encourage any provider that is standing before somebody that's hawking a product to ask questions.
Oh, yeah.
Where are you licensed? What
yeah.
states are you licensed in? Are you federally registered? Tell me about your products. Where do you get your products? You can't ask enough questions. I mean, I did a deep dive on the New England Compounding Center years ago, and one of the overarching themes was too good to be true. They were selling a product that was, I can't remember the exact numbers, but just making them up, they were selling something for $10 when everybody else was selling it for $50. And ask questions.
Right.
How does that happen?
I mean, it doesn't take much to get hurt in these situations, so be careful.
Yeah.
Make sure people that you're going to see are licensed and trained and working within the scope of their practice.
Do you often see that as manufacturer training?
Most of the time, manufacturers will provide the training.
Yeah.
But there are, more and more Botox. I get them all the time. I get emails to, do you want to be trained to do Botox? I'm like, no, I do not. But, or to do filler. It's like, no, I don't want to take that class. But there are companies now that train nurses and physicians and NPs to do those things. And what does that curriculum look like? Is there a standardized curriculum? I don't think there is.
Yeah.
So, how much training did this person actually do? Without
trying to be members of the Board of Medical Examiners, their delegation policy says appropriately trained.
That can mean a lot of things.
And that is very broad.
Yes.
That is very broad.
Yes.
I would think that some element of everything that we've just described would be appropriately trained.
Yeah.
And not just, here, watch this YouTube video and then...
And you're free to do whatever.
Yeah. That feels like two or 5 steps too few. Do you see the AI boom in coming into the profession?
Yes, and it's good and bad. I mean, it's very helpful in certain things like tracking and looking at trends with patients, and even smaller changes. It can track certain things. It's great for like EKG interpretations, radiology. I'm a little leery about it documenting. I don't know if it really gets the full, context of what was done and said. But at the end of the day, I mean, you're still going to need a nurse because nothing replaces a touch or a skill or a hug or, that compassion.
Yeah.
Unless you invent a robot that does that. But I don't see that part happening. So you're still going to need the nurse there.
Right.
But I always tell people, I'm like, lean into it as much as you feel comfortable with right now. But it's coming, but let's use it wisely.
I have a client in East Tennessee that implemented an artificial intelligence type of electronic record-keeping apparatus at their practice. And what it captured, this is a shout-out for the technology, in a sense that it allows the providers to actually do what the provider's supposed to do, which is deliver health care.
Right. And it can catch a lot of things. Like, I know when electronic health records and electronic charting started, And the nurses were like, well, it's going to tell me I'm running late on all my meds. And I'm like, why don't you want the hospital to know that you're running late on all your meds because you're overworked? I was like, that's what it's telling me, that if you can't, every nurse can't get their meds in on time, this is a system problem. This isn't a you problem. So I think with AI could also be very helpful, just reminders of things that pop up, just an extra layer of security.
Sure.
But it's not going to replace, nurses. No. I don't think so.
No.
I hope not.
I get that question regularly. Do you worry? And no, I think that lawyers that don't use AI will be replaced.
Right.
But it's not there yet.
Right.
It's just not there
It's
yet.
not there yet. It doesn't, I would tell my students, I'm like, it doesn't do a very good job prioritizing things either right now. It hasn't learned how to prioritize, and that's a very important part of nursing, is knowing what to do first and in what order. And so it's not there yet. It probably will be next week. But
Ours is what we see as citations. It hallucinates and just makes stuff up.
Yeah.
And as soon as it stops doing that, it's going to be very tight with what it's doing. But I still have to read it.
You got to check your citations.
Can't just submit.
I did that. I was like, give me a list of 10 articles about this topic, and I think half of them were actual real articles. After COVID, I mean, it was a struggle. I mean, COVID was tough. I mean, I wasn't in the trenches, but I was doing a lot of the vaccinations just around Memphis. The schools kind of stepped up and did a lot of vaccinations, and we were running ourselves ragged doing that, but I couldn't imagine what the ICU nurses were doing. And then just the stories you were getting coming out of that. And it's like, no wonder people are leaving. I mean, they just talk, it's like a war zone, the way they described it. So, and then saying, oh, come join us, come join this field. And they're like, no, I'm not coming. It's like, why would I do that?
I worked directly with healthcare providers for 13 years and was so blessed to have those relationships because but to see healthcare providers concerned, I use the analogy that, if there's turbulence on the plane, I look around to see if
anyone's freaking out.
Any of the crew, like the random pilot that's in row 30, is he okay?
Yeah.
When the healthcare providers were concerned, that was a telltale to me that this is...
It was bad.
Yeah.
It was bad. Yeah.
And they were. They very much were.
Let's hope we don't have that again in our lifetime.
Agree.
Yeah.
Doc, thank you for
appreciate
joining.
it. Yes, thank you so much. Anytime.
All right.
Yeah.
Thank you.